Why have we spent all of this time talking about the synthesis and degradation of glycogen? Well, it's important to know the pathways of glycogen synthesis and degradation so that now you can appreciate the disorders of glycogen metabolism. What happens when we have a deficiency or a defect in one of these enzymes here? Well, the glycogen storage diseases are all going to be caused by abnormal glycogen metabolism, which can cause damage by allowing glycogen to accumulate to toxic levels within cells. There are 12 main types of glycogen storage diseases. However, we'll cover just the most commonly tested ones. All four of these are going to be autosomal recessive. Expect to see at least one or two questions regarding the glycogen storage diseases on the USMLE, so this is going to be a very high yield section to know. We're going to start off our discussion with type 1 glycogen storage disease, also known as von Gierke's disease. This is going to be caused by a deficiency of the enzyme glucose 6-phosphatase. I have it circled down here. Remember, glucose 6-phosphatase is going to convert a glucose 6-phosphate into a molecule of free glucose so then it can leave the cell and travel to other parts of the body. Muscles actually lack this enzyme since they're greedy and they want to use all of that liberated glucose produced from the breakdown of glycogen for themselves. It may be helpful to think that von Gierke's disease is going to affect mainly the liver, and then to a lesser extent the kidneys. So here we have increased glucose 6-phosphate levels due to a missing enzyme, therefore we're going to increase glycogen synthesis. So let's go ahead and think back to the right-hand chart of this figure here. If we have a buildup of glucose 6-phosphate, what's going to happen? Well, since glucose 6-phosphate activates the enzyme glycogen synthase, we talked about that earlier, so if we have increased glucose 6-phosphate levels, or it accumulates in a cell, then even more glycogen is going to be formed. We're going to activate this enzyme. Consequently, patients with von Gierke's disease have increased glycogen stores in the liver and also severe fasting hyperglycemia, since this glucose cannot be dephosphorylated by the enzyme glucose 6-phosphatase and therefore it cannot leave the liver. This can also increase the blood lactate, which can lead to gout due to increased urine pH and can cause hepatomegaly or hepatosteatosis, which is known as fatty liver. Some other effects are going to include renal failure, delayed puberty, and hepatic adenomas. Von Gierke's disease is treated with frequent bouts of glucose to hopefully ward off that hypoglycemic state since the liver is unable to compensate for the low blood sugar. We're not able to break down the glycogen into a free glucose molecule because we're not able to liberate that last phosphate. Also, affected patients should avoid fructose and galactose. Type 2 glycogen storage disease, or Pompe disease, is caused by a deficiency in the lysosomal alpha-1,4-glucosidase enzyme. As I mentioned before, this enzyme is going to break down glycogen into glucose in the lysosome. This is going to be a very serious disease that primarily affects the liver, heart, and skeletal muscles. Remember that Pompe's disease is going to trash the pump, meaning mostly going to affect the heart, but also other organs as well. The main finding in Pompe disease is cardiomyopathy, along with other systemic findings like exercise intolerance. If you suspect a glycogen storage disease that focuses on the heart being affected, you need to have Pompe disease on your differential. The third type of glycogen storage disease, known as Cory's disease, is caused by a deficiency of our debranching enzyme. What was the function of the debranching enzyme? Well, remember that the debranching enzyme is required to break down the glycogen into glucose by cleaving off the alpha-1,6 bonds at the branch points, along with some alpha-1,4 bonds at the limit dextrin points. This primarily affects the liver and the muscles and has findings similar to type 1 von Gierke's disease without that lactic acidosis. Again, these symptoms are going to include hepatomegaly, hypoglycemia, and delayed growth. The hypoglycemia is going to be milder in Cory's disease than it was in von Gierke's, and symptoms in general are more benign. This is because Cory disease does not affect gluconeogenesis, which is impaired on von Gierke's disease because glucose remains trapped in the liver as glucose 6-phosphate. We're going to skip type 4 glycogen storage disease because it's not very high yield for the test, and we'll move straight into type 5. So type 5 glycogen storage disease, or McArdle's disease, is caused by a deficiency of skeletal muscle glycogen phosphorylase, so right here, also termed myophosphorylase, myo meaning muscle. Consequently, this only really affects skeletal muscle and not cardiac muscle. You will see increased glycogen in muscles with an inability to break it down. So how may a patient with McArdle's present? Since muscles cannot get enough glucose from breaking down glycogen, this can cause muscle cramps, myoglobinuria, muscle weakness with myoglobinuria during strenuous exercise, and arrhythmias due to electrolyte abnormalities. Would you expect to see hypoglycemia in the bloodstream? Well, no, since McArdle's disease does not affect the liver, which is going to break down the glycogen stores into free glucose, and that free glucose can then go on to the body. Remember, muscles are greedy. They're going to keep all of the glycogen breakdown products to themselves. So actually, the blood glucose levels is usually going to be unaffected in McArdle's disease. We now have to dust off our memory and jump back to cellular biology and then think about the organelles within a cell. Do you remember what the lysosomes do? Lysosomes are organelles whose main function is to break down unwanted molecules using a variety of different enzymes. A deficiency in one of these enzymes can cause a lysosomal storage disease, which results in the accumulation of a sphingolipid or a mucopolysaccharide in specific cell types. Here's an example of a sphingolipid, here's an example of a mucopolysaccharide. The structure is not important. However, there are many buzzwords that you will need to know for these lysosomal diseases. To make life a little bit easier, we've already seen one of these lysosomal enzyme disorders. Do you remember what the disease is called when lysosomal alpha-1,4-glucosidase enzyme is missing? Hopefully you remember the good old Pompe disease, which is one of our four main glycogen storage disorders. Now back to our lysosomal storage diseases. The lysosomal storage diseases in general are going to accumulate metabolic byproducts and mostly affect children, which are often deadly at a young age. They're all going to be autosomal recessive except for Fabry's disease and Hunter syndrome, both of which are X-linked recessive. You'll probably get a question on your step 1 that asks you to identify the specific disease, the inheritance pattern, a deficient enzyme, what substrate is accumulated, or what clinical findings are going to result from one of these lysosomal storage disorders. To get these questions right, you should take some time to memorize these diseases and pay particular attention to what distinguishes one from the other. As usual, we've provided some good ways to help you remember these. We will first start off with the sphingolipidoses, which will include Fabry, Gaucher, Niemann-Pick, Tay-Sachs, Krabbe, and metachromic leukodystrophy diseases. Let's go through each one of these one at a time and talk about the major talking points. Fabry disease is a deficiency of the enzyme alpha-glucosidase A, which will lead to an accumulation of ceramide trihexycide. What were the two X-linked recessive lysosomal disorders that we talked about earlier? Well, hopefully you're thinking Fabry disease, I have it listed here, X-linked recessive. So we're talking about that one now, but also Hunter syndrome is going to be X-linked recessive as well. All of the other lysosomal disorders that we're going to cover are autosomal recessive, except for these two. Fabry disease can present with angiokeratomas, which are a capillary disorder seen here. Gaucher disease is the most common lysosomal storage disorder. Since it's the most common, you can bet that your chances of seeing it on test day are pretty high. Which enzyme is deficient or defective in Gaucher disease? Well, our enzyme glucocerebrosidase, aka beta-glucosidase, is going to be defective or missing, which leads to an accumulation of glucocerebroside. Another important pearl to Gaucher's disease is how the cells look. So here's our slide. Now notice that the Gaucher cells are lipid-filled macrophages that look like crumpled tissue papers. So here's a Gaucher cell, for example, that I'm kind of outlining here. You may also be presented with a young child who presents with symptoms of hepatosplenomegaly, pancytopenia, osteoporosis, and aseptic necrosis of the femur. Be prepared to see a picture similar to this one on test day and be able to tie it into Gaucher's disease. Niemann-Pick disease is caused by a sphingomyelinase enzyme deficiency, which is going to lead to a sphingomyelin buildup. What's a quick and easy way to remember this on test day? Well, you can remember that you use your finger to pick your nose. Sphinger is going to represent sphingomyelinase or sphingomyelin, and pick is going to be Niemann-Pick disease. So use your finger to pick your nose. In Niemann-Pick disease, you'll see lipid-laden macrophages called foam cells, a buzzword. Also, if the question prompt says that on fundoscopic exam you see this, you see cherry red spots. Niemann-Pick disease should cross your mind immediately. An excellent way to remember which diseases have cherry red spots, so it's seen down here, is by looking at a hyphen in the name. Cherry red is going to be hyphenated, and so is Niemann-Pick and Tay-Sachs disease, both of which have hyphens in the name as well. So Tay-Sachs disease can present with cherry red spots as well, like I just said. Tay-Sachs is another extremely high-yield disease, so remember that GM2 ganglioside is going to build up due to the lack of the hexosaminidase A enzyme, because Tay-Sachs lacks hexosaminidase A enzyme. If you hear or see a lysosome with an onion skin appearance, I want you to start cluing in to Tay-Sachs disease, another high-yield buzzword. And finally, what are our other two sphingolipidoses? Well, that'll include our Krabbe disease and our metachromic leukodystrophy, both of which are two more lysosomal disorders that result in an abnormal breakdown of sphingolipids. While they are less important, make sure that you still know them for test day. Also note that their inheritance pattern, like I said, is going to be autosomal recessive, except for our two outliers which we've already discussed. The mucopolysaccharidoses can be classified into two different yet similar disorders. Hurler syndrome is going to be where we start. Hurler syndrome is due to an alpha-L iduronidase enzyme deficiency, which is going to lead to the accumulation of heparan sulfate and dormatan sulfate. Hurler syndrome is the more severe between these two, so if you're ever diagnosed with Hurler syndrome, you'll probably want to hurl. Symptoms are going to include corneal clouding and gargoylism, which is just joint and movement restriction. Then you may also see hepatosplenomegaly as well. Do you remember what the two X-linked recessive lysosomal storage diseases were? I'm really trying to drill home this point because all lysosomal storage diseases are going to be autosomal recessive except for these two. And hopefully you're thinking Fabry disease and Hunter syndrome, the latter of which is our final mucopolysaccharidoses. Hunter syndrome is just going to be a milder form of Hurler syndrome, without the corneal clouding, but it does include a little bit more aggressive behavior. Notice how the same products are going to accumulate in both mucopolysaccharide disorders. I know what you're thinking at this point. How am I going to remember all of this information? Well, I agree with you. Reading through all of these from the beginning to end will result in a lot of going in one ear and out the other. So I recommend that you try and memorize these in a very methodical manner, such as making sure that you're very familiar with each disease before moving on to the next one. Also return to these often and quiz yourself. Please make sure you know these because they will show up on test day. To learn the clinical findings for the lysosomal storage disorders, let's go ahead and focus on the distinguishing characteristics of each disease. Fabry's disease is going to be notable for angiokeratomas, Gaucher's for bone necrosis, and metachromic leukodystrophy for ataxia. Both Niemann-Pick and Tay-Sachs disease have cherry red spots in the macula, but Niemann-Pick will also have hepatosplenomegaly, whereas Tay-Sachs will not. Hurler syndrome is notable for corneal clouding, which is not going to be present in Hunter syndrome. Our disorders that have hepatomegaly are going to include Hunter and Hurler syndrome, Niemann-Pick disease, and Gaucher's. What three diseases should come to mind if you see the word Ashkenazi Jew in the question prompt when referring to our lysosomal storage diseases? Well, the term Ashkenazi Jew should clue you into Tay-Sachs, Niemann-Pick, or to a lesser extent Gaucher's disease. Let's do a quick practice question now before moving on. A patient is diagnosed with Gaucher disease. What is the deficient enzyme? What is the accumulated substrate, and what is the inheritance pattern of Gaucher disease? Well, our missing enzyme is glucocerebrosidase, which causes glucocerebroside to accumulate. And remember that all lysosomal storage diseases are autosomal recessive, except for our two X-linked recessive diseases, which are Fabry and Hunter. So Gaucher is going to be autosomal recessive.